So, Frank, vaccines. I grew up, in Uganda and Kenya, and I travel to East Africa regularly. So I'm just full of vaccines. I mean, it's the yellow fever, it's the hepatitis, all kinds of stuff. But people who live there in these endemic areas, a lot of them never get access to those vaccines that we can just take like this because we're going on holiday. That's a problem, isn't it?
Yes, it's a problem. I feel perforated as well by vaccines, but many who need them, they don't get them. Take hepatitis B, for instance. There is a very effective vaccine. There are good treatment guidelines for those who are infected. And still, people who are infected living in high endemic areas such as sub-Saharan Africa, they don't get access to follow-up or treatment. And our next speaker, he has established a long-term relationship, research collaboration with colleagues in Ethiopia. And together they aim at making hepatitis B treatment accessible to those who need it. And not only has this benefited people living there, but his work has also generated several Ethiopian and Norwegian PhDs.
Asgeir Johannessen is Deputy Director of the Center for Global Health at the University of Oslo, and he's a senior consultant at Vestfold Hospital. As we speak, he's attending a hepatitis conference in Tanzania. So he can't be here, but he sent us a video. So let's hear what he has to say.
Thank you for that introduction. I will talk about my favorite topic, which is hepatitis B and hepatitis B elimination in Africa. And I will share with you some of the highlights from our work in Ethiopia. So first, why should we at all worry about hepatitis B? The reason is this: it's close to 300 million people who are chronically infected with hepatitis B, and out of these, 20% will die from its complications, which is a lot of people. And then some people argue that other diseases are more important, like HIV, malaria, and tuberculosis. And that was true when I was a student, but it is no longer true, as we can see from this slide. Mortality from all these three diseases have declined over the past decades, but the orange line, viral hepatitis, has increased. And today, more people die from viral hepatitis than from HIV and malaria together. Viral hepatitis is not only one virus, it is A, B, C, D, E at least. But as you can see from this slide, B is by far the most important. B kills twice as many people as all the other hepatitis viruses together. And that was the reason why the World Health Assembly endorsed a plan in 2016 to eliminate viral hepatitis as a public health threat by 2030. And many countries are on track, especially for hepatitis C, but not at all in sub-Saharan Africa. And the main barriers mentioned are lack of funding, poor access to laboratory tests, and complex treatment guidelines that are just not suitable in low and middle income countries, regulatory issues on antiviral drugs that prevent people from using them to hepatitis B patients, and also a lack of political will. All this despite the fact that several studies have shown that inaction is more expensive than action when it comes to hepatitis. And some of you are old enough to remember having heard all these arguments before. These were exactly the same arguments that people used to oppose scaling up HIV treatment 20 years ago. And as we know, those people were wrong. Scaling up of HIV treatment has been a tremendous public health success story. And I believe the same could be done for hepatitis. So that was the bigger picture. Then I need one slide about the smaller picture. Hepatitis B is a DNA virus that infects human hepatocytes, human liver cells. The disease has been known for a long time, and the virus itself was discovered more than 50 years ago. And we have had an effective vaccine since the 80s, which means that this is a disease that could be eliminated. Transmission in our part of the world is typically sex, drugs, and rock and roll, but globally, this is a childhood disease. Children get it in early childhood, either through delivery and childbirth or from other kids. And the long-term complications of Hep B infection comes after 20, 30, 40 years, when people die from these two complications, either hepatocellular carcinoma or liver cancer, or cirrhosis or shrunken liver and liver failure. And both of these complications can be prevented by antiviral treatment. But still, as this slide shows, in Africa, only 2% of those living with Hep B infection are aware that they have the virus, and only 0.1% receive treatment, which is, of course, a complete failure. So why is it so hard? I mean, Hep B treatment, in theory, is super simple. It's 1 tablet of tenofovir per day keeps the complications away. But the tricky part, which is different from HIV, is that only 20% needs treatment. As I said, only 20% die from it, which means 80% don't need treatment at all. And international guidelines are based on complicated and expensive tests like liver biopsy, elastography, PCR, and so on, and they just can't be applied in resource-limited settings. So this was the reason why we decided to set up a pilot Hep B program at this hospital in Ethiopia in 2015. And we adapted the European guideline and made a simpler treatment algorithm. We used generic drugs, which are not at all expensive. We had a nurse-led patient follow-up. We enrolled 1,303 patients in 2015, and we have been following them up since. This was done with funding from Helse Sør-Øst and Forskningsrådet, and it has generated many nice scientific articles, 2 Ethiopian PhDs, and many happy and living patients. And these are some of the initial publications, and I am particularly proud of this one, which brings us to policy, because the WHO, they issued guidelines already in 2015 for how hepatitis B could be treated in resource-limited settings. And since then, I and others have argued that these WHO guidelines have just put the bar so high for treatment that it prevents people from getting life-saving treatment. If you use the WHO guidelines, then very few will end up being treated. So it's sort of a lost opportunity for treatment. But the WHO wouldn't listen, and that's why it was sort of nice to use science to show that to show our points. And what we did here was to assess all our patients with a gold standard, which was the European guideline, which is sort of the best we had. And then we compared the gold standard with the WHO guidelines. So close to 1,200 patients were assessed with the gold standard, and if you follow the yellow track, you can see that 300 of them should receive treatment according to the gold standard. But only less than half of them were detected by the WHO criteria, which means that the sensitivity was 49%. Half of those who needed treatment didn't get it. But in fact, the real situation was even worse than this, because our cohort is a hospital-based cohort, and we had a lot of people with very advanced disease, which is not the reality when we roll out this at other places. So when we removed those with decompensated advanced liver disease, then the sensitivity was only 25% of the WHO criteria. But so what? I mean, we published some papers and we set up this cohort, and we were hoping the world would follow, that this would be sort of an inspiration to others, like in the early days of HIV treatment. And that has not happened at all. Still today, less than 1% of Hep B patients in Africa receive therapy, which is sort of depressing for us. And we could, of course, give up and find something else to do. Or we could step it up to the next level, which is what we decided to do. So we realized that our pilot program was set up in the capital at a nice hospital and maybe not generalizable to most hospitals in Africa. So 1.5 years ago, we started this scale-up Hep B program in Ethiopia, which was going to be simpler and cheaper and hopefully just as good. We took it out to 4 regional hospitals. This picture is from the first hospital we started, which was in Jimma. We aim to enroll 6,000 patients. We are almost there. And we did this with funding from Helse Sør-Øst and John C. Martin Foundation. And this time, rather than using European guidelines, we used local data from Africa, from the pilot program and from the HEPSANET collaboration to develop a locally adapted, simplified treatment algorithm for Africa. And we are in the process of evaluating this program now, and the results will follow in the coming 1 to 2 years. And that brings me to HEPSANET. What is HEPSANET? HEPSANET was something we invented. Our group in Ethiopia, we contacted colleagues who were involved in hepatitis B care in Africa, and we invited everyone into this collaboration because we realized that we are a quite small number of people who are interested in this disease. We have our small to medium-sized cohorts, but if we really want to have impact on policy, if we want to convince the WHO that how hepatitis B should be treated in Africa, we need larger studies. So the idea here is to generate large conclusive studies rather than a lot of small and inconclusive studies. So the first thing we did was just to merge cross-sectional data. Quite simple, quite quick. Didn't cost us a lot, except energy and time. The second phase is to collect longitudinal data that has started, and it's a lot of work. But it will be much more interesting, and hopefully it can answer some of the unanswered questions in this field in Africa. This was our first joint publication. It was published earlier this year. It is a meta-analysis of these 11 cohorts in 8 different countries where we assessed non-invasive fibrosis markers. That is cheap, simple markers to detect those who have liver injury who should receive treatment. We assessed these simple markers like APRI. APRI stands for AST to platelet ratio index. It is what the WHO recommends to use to detect liver injury in poor countries, basically. And the WHO used these thresholds, which are derived from studies in North America. And we showed here that the sensitivity of these WHO recommended thresholds was 11% for fibrosis and 16% for cirrhosis, which means that in clinical practice, it's completely useless. You will fail to detect 84% of those who have cirrhosis, and they will just go on and die. But rather than just saying that the WHO is wrong, we went on to identify the optimal thresholds. This slide is a bit busy, but it shows how we detected the optimal rule-in threshold for cirrhosis and rule-out threshold for cirrhosis. So this was a very practical article. It showed how this could translate to policy, basically. What should be the cutoff? What should be the guidelines for Africa? And we wanted to advertise this better than just publish it in a single article. So I wrote this comment in the Lancet Global Health together with Haile Mikkel, my postdoc in Ethiopia, and Dr. Lia Tadesse, who is the Minister of Health in Ethiopia. And we showed what we have been doing in Ethiopia and in HEPSANET, and we proposed this as the treatment guidelines, as the new WHO treatment guidelines. And just 1 month or so after publishing this, the WHO invited us into the group, into the working group for new WHO guidelines. And that has been a long process, but it seems that the WHO now will go for something very similar to what we suggested, which is sort of encouraging. So to summarize, our group started a pilot project in 2015. It was a small, nice project with a few people involved, 2 PhDs, small grant, simple studies. Then we grew from that, and we decided to expand a couple of years ago, aiming for high impact studies and larger grants. And we employed 5 Ethiopian PhDs in this program. And then the most important we have done, I think, is to initiate this international network called HEPSANET, where we aim for impact. We aim for impact on policy and large grants. And I just want to underscore that the impact on policy came after 10 years of hard work. It doesn't come easily. But this underscores an important point, because we are so used to, in research, to get grants for 3 years, 4 years, something like that. But I believe to really make a difference, we need to dare to think beyond the 3-year project perspective. We need to build structures in faith for 10 years. This is, of course, a collaboration with a lot of partners in Ethiopia, Norway, and beyond, and I want to thank all of them. And thank you for listening.